We'll go ahead and get started. Can everyone hear me okay? Okay, perfect. All right, so welcome to Project Echo. Next slide, please. Today's agenda includes a topic on navigating insurance for hepatitis C treatment in children, and that will be presented by Dr. Ligia Alfaro Cruz. We will also have a couple of case presentations, a hot topic session, and then also closing remarks. Next slide, please. As always, in order for you to receive your continuing education credit, please make sure that you do register through the SEA ETC site. You can click on the QR code or register through the link, but that will be the only way that you can get your continuing education credit. Next slide. Just a few introductions and announcements before we pass over for the presentation. Please introduce yourself in the chat. Include your name, your role, your organization, and if this is your first Echo session. We'll give just a couple of minutes for people to do that before we start into the presentation. If you have any tech issues today throughout the session, please reach out to Anastasia Cahigal, and she can assist with those issues. Please just remember to keep yourself muted, but if you do have a question, please feel free to raise your hand or come off mute or put a question in the chat. And I see there are several people putting their introductions in the chat. I appreciate that. All right, so we will go ahead and get started. Dr. Alfaro Cruz, would you like to take over with the presentation?
Hello, yes. Hi, good afternoon, everyone. Thank you for joining us today. We are going to talk about navigating insurance for Hep C treatment in children. And this is, I think it's going to help to get along with the next talk in 2 weeks regarding navigating insurance with adults and cover how can we help our patients to not only receive a right diagnosis, but treatment and make sure that treatment gets to them. Next slide, please. I have no financial disclosures or conflicts of interest to report. Next slide, please. So we have talked about this and why Hep C is so important and why we're doing this this Project Echo in order to talk more about these. It's because we know that at least right now, we have 150 million infected persons in the world. And this number is actually increasing as we speak. We know that there is at least 11 million people that are less than 15 years of age that are being affected. That chronic Hep C, it's infection, it's a chronic illness of the liver that can lead to severe chronic disease, as well as other complications, including increasing morbidity and mortality. And that the emotional burden is actually more difficult to estimate as it affects not only the patient, but as well their family member and their loved ones. Next slide, please. We have discussed this in previous talks, so just kind of a small review about the different options that we have, especially with these new medications, these direct-acting antiviral medications that have significantly changed how we're treating Hep C. And as we can do now, 8 weeks to 12 weeks regimen with one pill that can cover multiple genotypes and see completely cure of Hep C. Next slide, please. So going on, talking about these drugs, medications, it's important to know the ones that we have available to treat children. In this case, let's kind of do a reminder of our sofosbuvir velpatasvir, which is the brand name Epclusa, that we're using it to treat for 12 weeks patients who have Hep C genotypes 1 through 6. And this is just a reminder of the doses and how we are calculating those based on their weight. Just a reminder that or every kid that it's above 3 years of age, or he can actually get treatment. Next slide, please. Another option that we have for children is called lenacapavir, sofosbuvir, brand name Harmony, with a duration treatment of 12 weeks, again, indicated for kids that are older than 3 years of age. And as you can see here, this is just a reminder of the body weight that we use to calculate the dose on these patients. Next slide, please. And the last one that we have as well, actually, let's go back the previous slide, please. And we'll talk about this, but brand name Harmony right now is only able to treat genotypes 1, 4, 5, and 6. So this is one of those that would not, if your patient has genotypes 2 or 3, would not be indicated for. Next slide, please. And our last drug that we can use to treat children, name is glecaprevir, prevenstivir, brand name Maverick. And this is a total duration of 8 weeks. We do see a little bit of a change here in the weight, as instead of 17 kilograms, we're taking baseline 20 kilograms in these patients. Next slide, please. So when we talk about insurance options, and as physicians, this is kind of the part that a lot of the time will create a little bit of fatigue or burnout trying to deal with the insurance process. But we do have 2 good treatment options or 2 good insurance options in our state. The first one is Medicaid, and the second one is private commercial insurance. So we're going to start talking about Medicaid. Next slide, please. So when we talk about Medicaid insurance or teen care, some of the requirements that our patients have to have in order to qualify to get treatment are, 1, live in the state of Tennessee, actually have a physical address in the state of Tennessee. They have to be Medicaid eligible in order to participate in or be able to attain treatment. There has to be a Hep C viral PCR RNA viral load. That it's positive. We've had the previous Hep C antibody, and now we have a viral load. A genotype, I know this is something that we have discussed in the past, how with our medications being multi-genotype, we really don't need that. But for insurance purposes, for children, we are going to need to get a genotype. Other testing that will require from insurance will be an HIV antibody and a Hep B testing as well. And for those patients who have actually failed treatment before, and we are trying to get a second round of medication with a different agent, they would have to have a quantitative Hep C viral PCR RNA 12 weeks after finishing that first treatment. So we can actually prove that the patient has actually failed treatment. Again, we don't need a liver biopsy in order to start treatment for patients with Hep C. Next slide, please. So this is actually very good information that can help you, that you can actually find in the website that you can see below there, optumrx.com. And it actually tells you and helps facilitate what are the things that we need to get that medication. Now, all these medications will require a prior authorization. In this case, we're going to start talking about with sofosbuvir and velpatasvir, a brand name Epclusa, and this is talking about the tablets. Remember that now we have different presentations that we can give to young children who are not able to swallow tablets, and we'll also discuss about that. Now, what you have to know in this case is that this is actually can be given to any patient who has chronic Hep C with genotypes from 1 to 6. As we were mentioning before, they will ask you to have first if the patient has compensated cirrhosis or none, because duration of the treatment here will be 12 weeks, or if they have decompensated cirrhosis as well, or if they're going to get this in combination with ribavirin. Other things that they will ask us is to have, if there's any history of HIV, Hep B co-infection, if there has been any history of previous use of medications as well, and to provide in those cases quantitative Hep C RNA levels 12 weeks after treatment. Now, the genotype will be also asked from current and previous infections, and that the patient had been screened for Hep B. This is going to be limited to 1 a day tablet in this case. And as you can see here in that same website, you're going to be able to find the PA forms that you're going to have to fill out in order to get approval for the medication. Next slide, please. When we talk about the other presentation that we use in usually most of kids between 3 and 8, 9 years old, depending if they can swallow tablets, is the pellets. Now, in this case, we're going to use the same prior authorization criteria as before. The only thing that they're going to ask you is that you actually state that the patient is unable to swallow tablets, and therefore this is the indicated presentation for them. You can, there's some other patients that may have a swallow dysfunction, so you can actually put that in your paperwork or say that because of his age, patient is unable to swallow tablets. Next slide, please. This is an example of the form that you're going to find on the website that I think Lindsay just put on the chat. And it's going to ask you exactly the same things that we have talked about. And this is where you can actually put if the patient is not able to swallow tablets, then as you can see here in the non-prefer, you can click pellets and explain that the patient is a young patient as well. Next slide, please. Next one is lenacapavir, sofosbuvir, or brand name Harvoni. So in these cases we were talking, this is not indicated for Hep C genotypes 2 and 3. So they're actually giving you the different options in order for genotypes 1, 4, 5, and 6. As you can see here in the first lines, we are talking about if your Hep C RNA levels are less than 6 million, then it's going to be approved for 8 weeks. If it's more than 6 million IU per ml, it's going to be approved for 12 weeks. So this is just for you to be mindful when we're sending the prescription or the regimen dose as to what the insurance will be asked. Again, we're talking about the quantity limits, 1 a day. And in that same website, you're going to get a PA form that you're going to have to fill out in order to get it approved. They will ask very similar things. If the patient has cirrhosis, if he's decompensated, if it's a compensated cirrhosis, have they been tested for Hep B? Do they have an HIV testing? And for those who have failed treatment before, making sure that we have a 12-week RNA level after completion of that previous treatment. Next slide, please. Here we see for the pellets as well that we have that presentation. Now remember that these are not the these are non-prefer in the case of pellets, and we're using it mostly with, for example, kids that are unable to swallow, have a swallow dysfunction, and even those who have a G-tube and you cannot give, or it has a G-tube and you have to give another way. Next slide, please. Here, it's the form that you're also going to find on the website. Again, we're talking about very similar things as the ECLUSA form, where they're asking you the information that you'll have to fill, especially if the patient has been, it's naive to treatment or it has experienced treatment in the past. Next slide, please. And then our third and last option for children, we're talking about lenacapavir, prevensivir, brand name Maverick. Now, this is one that it's used for genotypes 1, 2, 4, 5, and 6. And then we'll see the other one with genotype 3. This is the one that you do for 8 weeks. But in patients who have a liver or kidney transplant recipients from a Hep C donor, then usually treatment will be for 12 weeks. They will ask very similar questions regarding if the patient had been transplanted, if we have co-infection with Hep B, HIV status, and also if they have been a naive, treatment naive, or have they experienced treatment. In this case, actually, it will be a 3-day, 3 tablets, 3 pills per day, and you can also find the Maverick PA form in that same website. Next slide, please. Here, it's another, in case your patient has a genotype 3. Now, it's important to remember that most of our children, usually the most common genotype that they will have, it's going to be 1A or 1B. But in those cases where they have a genotype 3, then this could be an option. It talks about the patients that have without cirrhosis for a total of 8 weeks, those who have been kidney or liver transplanted for about 12 weeks, and then those who has compensated cirrhosis. They're going to ask, and that has happened, that if your patient has failed before treatments, then they're going to ask you again for those 12 weeks after completion. Next slide, please. And so Again, very similar, like Harvoni and Epclusa, where if you're going to use pellets, they're going to ask you to state why the patient needs this, as this is not the preferred presentation for the medication. Next slide, please. In this case, very similar to the form that you're going to see. They're going to state which genotype the patient has, and so on. Next slide, please. Now we move into the private commercial insurance. And these, I did a little bit of research on most of the private commercial insurance. The requirements are very similar, and you're going to see very similar requirements to the one that Medicaid also asks. So let's go into it. Next slide, please. So in the case for sofosbuvir, velpatasvir, brand name Epclusa, the requirements, they may not be as in detail as we were finding it on OptumRx, but they're going to be required for all FDA-approved indications of Hep C. If there is an infection, you're going to have to send the information about confirming that there is an active infection with the presence of HCV RNA in the serum. What's going to be your planned treatment regimen for that patient? And that's when we're talking about 8 weeks versus 12 weeks. The genotype, it's also going to be requested. And if there is any prior history of treatment history. The other thing will be if they have cirrhosis or if they don't have, and if there is any presence of HIV infection as well, or co-infection with Hep B. They are going to be specifically asking about transplantation status. If a patient has, especially in children, we tend to see more regarding those who go into acute liver failure and require liver transplantation. Sometimes a donor can be a Hep C patient. So in that case, we need to actually explain about that. Or those kids that have had a hepatoblastoma, require liver resection and a transplant, and sometimes a donor can be a Hep C, the liver can be a Hep C positive, then those are going to be the ones that you're going to need to specifically state whether it's a Hep C transplant status. The coverage conditions in this case are taking more about what the American Association for the Study of Liver Disease and Infectious Disease Society treatment guidelines, and those are the guidelines that we were talking a little bit early in the presentation. And then the criteria will be applied consistent with the current AASLD guidelines, which is pretty much the ones that also the Tennessee Department of Health follows through it. Next slide, please. Very similar with Harvoni. Again, in this case, we need to be mindful that Harvoni will not cover genotypes 2 and 3. So when we talk about the FDA-approved indications, those are going to be something to take into account. They all will ask about the genotype, a Hep B and an HIV, and the transplantation status. Now, in this case, just kind of a reminder about the guidelines that talked about 8 weeks option, if appropriate, especially for those that had less than 6 million copies of the virus. Next slide, please. And last but not least, lenacapavir, prevensivir, which very similar again, all this requirement, and these are actually very common find across all the different commercial insurances that we have. Again, they're going to ask about the compensated cirrhosis, moderate or severe hepatic impairment, the genotype, what's your planned treatment regimen in this case, if there is any absence or presence of cirrhosis, HIV, or any other resistance-associated substitutions where applicable. Following the AASLD, IDS guidance as well, and the treatment guidelines that we have discussed before. Next slide, please. Now, what happened in those cases where our patients are not covered by any insurance, are not Medicaid eligible, or they don't have private insurance? So each of these medications that we have mentioned before, they do have patient programs with the goal to provide low-cost medications where they can pay up to $5 to $10 a month for the medication regimen. Now, I have put in the resources here of the different websites that the patients and even the physicians can visit to get more. They will ask for a healthcare provider prescription for the medication. You have to have actually applied for a PA and got it rejected. And so that way, if they actually have other specifically criteria that they ask, then they can actually apply for this $5 to $10 copay where they can receive medication. This is excellent. This is our excellent programs that can help us. A lot of the population that may not qualify for Medicaid, that may not have private insurance, or even if they have private insurance, their deductibles are so high that they cannot afford medications. So this is just something to have in mind when we're trying to work on getting the medications for our patients, how these patient programs can actually help us. And then again, we're putting the resources of Optum RX. They have enough information of the medications that we can do how their preferred levels or not. Something that it's important to remember when we're talking about commercial insurance is that most of our medications that actually treat Hep C are considered tier 5. So that means that they're all specialty medications that will require a prior authorization from a healthcare provider before these medications get approved. Next slide, please. Okay, so I think we're going to do an echo pause to see if anyone has any questions regarding insurance and Hep C in children.
I actually have a couple of questions, Dr. Alfaro Cruz, but I will let the audience have a moment before I ask. Please feel free to come off mute. Or if you're not comfortable, you can always put your question in the chat. Okay, so I wanted to ask, do the medications have any taste?
So the pellets, to be honest, they don't have any taste for children. And usually it can be recommended to mix it with, we can do puddings, we can do cereals, to take away the kind of the sensory texture of the medication, but they do not have any taste as to what I've known.
Okay. The other question I have, and then I do see we have one in the chat, is I know that pellets are not the preferred.
Mm-hmm.
Are the actual tablets able to be crushed?
Yes, so there has been, so interesting is, even though pellets are not the prefer, we have been able to actually get them approved for all children between the ages of 3 and 9, because we have said these are children, they cannot swallow pills, and we have been able to do that. Now, there are some special cases where some patients are, they have denied the pellets, especially in teenagers, that they say, I cannot swallow a pill, but we have done sometimes crushing the pill. Now, there are some kids too that have G-tubes, or adults too, where they have not able to swallow, and we have actually, and there's actually a case report where they actually had to crush the tablets given to the, through the G-tube, and that was actually provide to be effective for that. And I think Dr. Allen probably can give us a little bit of more information too regarding how, crushing the tablets versus the pellets.
Yeah, so in my experience, we haven't seen it on the ISMP do not crush list for any of the medications. It also is not in the package insert about it not being able to be crushed. We have had one patient where in that similar situation, they were on a G-tube. It was an adult patient, and we did allow the patient to do crushed Harvoni, and we were able to get a successful cure. So it's few and far between when I have those scenarios, but there's no evidence to say that they cannot be crushed, and we have had success with our one patient with being crushable. So yes, good evaluation for patients who can't be approved for pellets is an option to crush the tablets.
Great, thank you. It does look like there is one question in the chat. What is the youngest age a child can be treated?
So right now we're recommending 3 years. That's what the FDA has approved these medications, but also we are we're coming up with a consensus among all pediatric GIs that it's better to treat as soon as we're able to than delay care. I know there has been conversations about, what if the kid cannot swallow the pellets, or what if the kids refuse to? Maybe give him some time and then bring him back in a couple of years when he's more mature. But actually, we're trying to get sure that there has been different techniques that we can use in order to take those medications, but we want to treat as young as 3 years of age.
Great, thank you so much. And Dr. Chastain has actually put a link in the chat to a case series about outcomes for patients who, among adult patients across multiple medical centers who had taken crush medications, and they all achieved SVR. So that's good to know. All right. Does anyone else have any questions?